Hello, everybody. We're going to talk about chronic and neurodegenerative disorders. And today we're going to focus on Alzheimer's and Parkinson's. This is really effectively the Neuro 1 lecture this semester. So here's some of your learning objectives, and you'll need to check the topic guide as well. But I want you to discuss pathophys, clinical manifestations, diagnostic tests, pharmacologic treatment options, and nursing care of patients diagnosed with Alzheimer's disease and Parkinson's disease. Those two alone are huge. And we'll just really kind of be touching on the surface of these. So, Alzheimer's disease is a degenerative disease of the brain. And not only is there cognitive loss, meaning their thinking, their memory, their ability to recognize people, their functional ability, but it's actually physical as well. And on an MRI of someone with Alzheimer's disease, you will see shrinking of the brain, where the brain is actually, you can tell this because the space between the brain and the skull begins to increase. And there are certain areas of the brain that when they see larger spaces of that area away from the skull, between the skull and that area, that they are suspicious for Alzheimer's. And so you can see here that ultimately it's this brain degeneration and the brain losing its function that causes people to pass away from this disease. So Alzheimer's disease, also sometimes referred to as AD, is an irreversible dementia, and it's caused by nerve cell death, loss of acetylcholine, which is a neurotransmitter, and actual atrophy of the brain. Now, the pathophysiology is largely unknown, but one of the things we'll talk about when we're together is that we're learning more and more all the time about things that are correlated with Alzheimer's disease. We don't know if they're causative yet, but we think that they're definitely correlated. And I'm going to tell you one of those is lack of sleep. Another one is hearing loss and vision loss. Those two losses can actually also be a part of Alzheimer's. Now, there's also some genetic mutations that are visible, identifiable, and you could say, oh my goodness, you have the such and such gene, and that's associated with Alzheimer's. But I would say that is a small percentage of the cases. Most of them we just don't know. We do know that it's on the rise in our society, and we do know that it's taking a toll on our elderly populations. One of the things that's really interesting to think about is, are we seeing more Alzheimer's because people live longer? And I suspect that that's some of the case, is that people are living now well into their 80s and 90s. Whereas I think when I was born, the life expectancy was around 67. And now it's up into the late 70s. I think it's 79 or 80. So maybe we're just seeing more cases because we have more people with old brains. So some of the things that we see in Alzheimer's disease is we see two hallmark signs. One is beta amyloid plaques, and the other is neurofibrillary tangles. And these plaques and tangles are seen usually on autopsy. We can't see them unless we do a brain biopsy, and we typically don't do brain biopsies unless we have a real need to. So patients are diagnosed by behavior. Now, there are some new diagnostic tests for Alzheimer's that are out, and we'll talk about those a little bit more in class as well. So this loss of neurons, these plaques and tangles, lead to loss of neurons, which leads to brain atrophy, and loss of synapses and acetylcholine. So connections in our brain that we previously had are now broken or not functional. So the hallmark signs of Alzheimer's disease, probably the hallmark sign, is memory loss. And along with that is short-term memory loss. Some people have denial of memory loss and then impaired abstract thinking. So if I look at my own dad who has Alzheimer's, I can tell you all of these things apply to him except for one, maybe two. So progressive forgetfulness. So he is so forgetful at this point that he can't remember that he just told you that story 1 minute ago. So that short-term memory is pretty much gone. He has no ability to consolidate memories. If you asked him even about something that happened in the morning, like, how was your morning? What did you do? He can't tell me. He'll say, oh, a little of this and a little of that. He's really good at covering up for his deficits. So progressive forgetfulness, and I remember when he first started having these signs and symptoms, he likes to play bluegrass music and he's in a bluegrass. He used to be in a bluegrass group, and he would forget the words to songs when he was singing. They can become disoriented and confused. My dad does not know a lot of times where he is, what day it is, what month it is. He certainly doesn't know the year. Probably doesn't remember the president, but boy, if you want to get him talking, start talking about Trump because he is not a fan. He can't, failure of math calculations. My dad actually can still sort of do this. He can calculate like a tip. If someone tells him, he can't calculate the tip, but if you tell him what the tip is, he can add it on to the subtotal and then create the total. Behavior changes, so agitation and restlessness. For my dad, it's been more of he's definitely restless, but also definitely tired and just can't tolerate doing anything for too long. Just I think any kind of thing that requires a lot of cognitive engagement, like dinner out or something like that, he can only do it for a little while and then he kind of drops off in conversation because I think his brain needs to take a break. Depressed or hostile mood swings. I've not really seen that with him, but that is his personality is very kind and gentle and loving, and so it doesn't surprise me that we're not seeing that. Emotional upset. He is very emotional. He's a crier, my dad, and he cries more now. So he gets touched by things, and it's actually very sweet. So what happens in Alzheimer's is eventually there's progression from this, sort of lack of awareness, loss of memory to being nonverbal, a non-ambulatory state. They can even have difficulty swallowing and eating. And again, remember, their brain is shrinking in there. So my dad is not at that stage yet. He's still verbal. He's still very ambulatory, and he loves to eat. He doesn't eat a lot, but he loves to eat. He loves ice cream. Okay, so again, no biological markers, although we're going to talk about some new things that are on the horizon. CT scan or MRI is the most helpful. Really, MRI is very helpful for looking at the brain and what it looks like inside that skull. And then you want to rule out other causes like sleep apnea and maybe hearing loss and other things that could present themselves as maybe a lack of memory, but maybe, if you can help them be a little bit more tuned in to the world and what's happening, they will do better. So, treatment for this is basically There's very little. There's a few pharmacologic treatments, we'll talk about that, but really the only thing that you can do is just really maximize quality of life. And I would say that this is a time for what we would call palliative care, just an ability to make their life as good as it can be given their abilities and their functions. Like I said, my dad loves ice cream. He is as happy as a clam if I can bring him, salted caramel frappuccino from Starbucks. And does he remember that I did it an hour later? No, but in the moment he's happy, and that makes me happy. You can do some memory aids. So, for instance, they have a big whiteboard at their house, and my stepmom writes down all of the things that are happening that day, like doctor's appointments or whatever. That's very helpful for my dad. Otherwise, he turns around and asks her. He still does that too. They also have a big calendar for what day it is because he also asks that as well. You want to maintain unimpaired cognitive functions. So again, my dad plays musical instruments, so trying to give him opportunities to go play music is really, really great and really helpful. And then maintaining or improving the general state of hygiene, nutrition, and health. He's getting to a point now where he doesn't want to do anything. He says he does. Like he told me one day all about how he went to the YMCA and all the things he did there and all the machines he used. And then I came home and talked to my stepmom, and she's just looking at me and shaking her head like, no, he didn't do any of that. But he likes the idea that he did it. But when you really ask him, do you want to go to do you want to go to the gym and you could ride the bike or be on the treadmill? He's like, nah, I don't want to do it. So it's been challenging, and even getting him to take a shower has been a challenge. And then we're going to talk about treatments here. So one of the biggest ones that you'll see out on the market now is Aricept. And Aricept is an acetylcholinesterase inhibitor. So it prevents the breakdown of acetylcholine, which increases the amount of acetylcholine, which results in increased nerve impulses. So remember, more information being communicated across those brain synapses. And it's not curative in any way, but it might help in the moment. It might help make them a little bit more functional. It does have some side effects, so nausea and diarrhea, and then slow heart rate. Well, my dad has AFib and he has some other cardiac problems, and so his neurologist felt very strongly that he should not be on Aricept, that it was not worth the risk. The other really, really important thing to remember about this is that improvement in memory will not happen immediately upon taking the med. It takes 1 to 4 weeks. So you're gonna have to educate the family that this is going to take a while. So somebody may call you after a week and be like, this med isn't working. And it's like, you got to give it more time. So it's kind of like depression meds where it takes a good 4 to 6 weeks before it really kicks in. Another medication that is widely administered for severe Alzheimer's is memantine, which is Namenda, and it's an NMDA receptor antagonist. But again, you don't need to know that one. Your prototype is donezepil or Aricept. But anyway, memantine works by blocking glutamate activity and may slow progression of the disease. But again, none of these have been like wonder drugs for sure. Okay, Parkinson's disease. So Parkinson's and Alzheimer's, if you know those two diseases, you really know the big neurological diseases of aging. Yes, there's, Lewy body dementia and, myasthenia gravis and some other, you're going to probably talk about multiple sclerosis. But in terms of the elderly, these are common occurrences. So Parkinson's is a little bit different in that what happens is the patient begins to have physical signs before they begin to have cognitive signs. So you'll see rigidity, postural instability, tremor, bradykinesia where they move slowly. And I'm just going to put this out there. I know they say it's not the case, but I would bet you that Joe Biden, our president, has Parkinson's disease. He looks Parkinsonian to me in terms of how he has sort of a flat face, not super expressive. Well, he does still smile, but he's kind of hunched over. He shuffles his feet. And I haven't seen a distinct tremor, but I don't think we see him that up close. So, of course, the poster child for Parkinson's disease is Michael J. Fox, and he has had this disease since he was 29 years old. So, and I believe he's now, gosh, up into his late 50s. He's quite impaired at this point, but he has done so much for fundraising, for research, just for general public awareness of the disease. And gosh, think about just how devastating that diagnosis was to him. And yet, has really just sort of lived into that experience. And I have a lot of admiration for that. So pathophysiology, this is a degeneration of the basal ganglia, which leads to dopamine depletion and an excess of acetylcholine, and it causes fine tremors, motor dysfunction, and coordination problems. And if you listen to him now, he's got severe speech issues, gait problems. He's got all those things that were on the previous slide. There are two types, and the primary onset is after age 40, more common in men, and again, progressive and degenerative. So it will eventually take his life unless he dies from something else first. Okay, so let's talk about some of the symptoms of Parkinson's. So bradykinesia, if you break that down, brady is slow and kinesia is movement. So slow physical movement and mental responses. Monotonous speech, this kind of monotone, one note kind of speech. I am talking to you and I can only talk to you in this one. It makes you sort of sound like a robot. Tremors in hands and fingers. Fingers at rest can do this thing called pill rolling, and it's where you rub your thumb across your fingertips. And that's, it's involuntary. Tremors increase when they're fatigued. So you'll see that someone has a harder time at the end of the day than they do at the beginning of the day. Rigidity with jerky movements. There may be restlessness and pacing, a blank facial expression, and you'll see this term called faces. Sometimes it's facies, mask-like faces. And I see it again in Joe Biden when I see his face when he's thinking about something or like walking up to the podium. There's a open mouth kind of, kind of a frozen kind of look. Drooling, difficulty swallowing and speaking. This would be later on in the disease, and loss of coordination and balance. Some folks are going to end up having difficulty eating, sort of like also like Alzheimer's, and shuffling steps, stoop position, propulsive gait. So they are going to have a high risk for injuries. Okay, medication for Parkinson's. So one of the really common ones is cogen. It's benzotropine mesylate, and it's an anticholinergic. It restores balance of neurotransmitters because remember, there's too much acetylcholine for people with Parkinson's and not enough dopamine. And so it sort of restores balance of those neurotransmitters, and then as a result of that, reduces the symptoms that we see. You need to be very careful giving it to patients with angle closure glaucoma, myasthenia gravis, or bowel obstruction because it's going to make those things worse. Side effects are disorientation, confusion, dry eyes, and mouth, and constipation. And then what you're going to see is hopefully you're going to see an improvement in their appearance. So maybe they look a little more bright, little less mask-like. Perhaps their gait has improved. Maybe their tremors are less, right? So one of the problems with this drug, though, is it causes dry mouth. And so you're going to need to educate your patient about oral care, keeping their mouth moist with water, maybe candy, rinsing their mouth frequently. And this can impair your alertness, so they really should not be driving. Okay, and then the other one is carbidopa levodopa, known as Sinemet. So it's a drug that has a little bit of both of those compounds, carbidopa and levodopa, in it. And I have to tell you that when I was in nursing school, like a million years ago in the dark ages, Sinemet was the first med that I learned related to my elderly client in the nursing home. So levodopa increases the amount of dopamine available in the CNS. It increases the dopamine in the synapse. And so it allows for the patient to, again, have less tremors, etc. You have to use it in caution with people who have cardiac, renal, or psych disorders. And the problem with this is that it can be very restorative in terms of taking it and really improving people's tremors and things, but over time, the body gets used to this drug being added every day and kind of overrides it, and you get back to having the same kinds of Parkinson's symptoms. So it really is not used on everyone. It's really used for people who have really significant symptoms and need desperately to have a reduction in the symptoms. Side effects are that it can cause depression, involuntary movement, dyskinesia, orthostatic hypotension. In terms of your nursing care, you want to encourage your patient to take this at regular intervals to maximize benefit. So you want it to be long lasting. You want them to change position slowly because, again, this can cause orthostatic hypotension. And so they're going to feel better. They're going to be able to move easier, but you're going to have to remind them that they're going to have to make those changes from down to up slowly. And then don't administer this with a high protein meal. And I forgot why. There is an interaction there. And again, we can talk about it more in class. Okay, this is neurodegenerative diseases of Parkinson's and Alzheimer's.